Shall I start?
Yes.
Yes.
Okay. So, Assalamu alaikum wa rahmatullahi wa barakatuh. I am Muhammad Faisal Omar, 40 medical student. I think many of you already know who is talking due to the many activity that we have done together. So, inshallah, today I will be talking about brief nutshell about the physiology of thrombus formation and what is the importance of this process. And then I will talk about, which is the most important part here, how to approach a bleeding disorder from a clinical point of view. And then we will talk about hemophilias, how to diagnose them, treat them, and at the end, some pharmacology, mainly about warfarin and heparin. And the rest of the topics will be dealt with the next lecture, inshallah. Okay. So starting with the thrombus formation story. Now, basically, you have to. I wrote this sentence in all of the slides in order for you to know that this is a balance. Our body is in a balance, and any time this balance is interrupted, you might go through bleeding or you might go through clot formation, will result in embolic conditions or embolic uh, events. Okay, so before going through the physiology, I want you to differentiate between these two terms, coagulopathy and thrombophilias. Now, when we say thrombophilias, we mean that the body is in a thrombus forming state. The body loves to form a thrombus, and usually these conditions are hereditary, okay, uh, or they can't be acquired as well, okay. So in these conditions, the body is not in a balance, so the body will form many clots, and that will result in embolic events that might result in ischemia, in ischemia anywhere in the body. You can imagine. The next term is the coagulopathy. Now, in the coagulopathy is the reverse, is the opposite. So in such a condition, the body will not be able to form the clots. So you will go into a bleeding. This bleeding might be external. It might be hemorrhage, okay, due to any kind of injury. It might be internal hemorrhage, or it might be very superficial small bleeding. So you have to understand this balance, okay? So the whole thing start with an endothelial damage. So now the formation of thrombus, when we talk about the formation of thrombus, this process consists of mainly of two things, primary hemostasis and secondary hemostasis. And I believe that the primary hemostasis has been discussed previously. But for your refreshing, okay, now you know that we want to form a clot. So the formation of clot is two phases. Sorry, starting with the platelets. The platelets are the main player at the start of the thing. Okay, so here the platelets will try to form a very fragile, but they will try to form a clot, but this clot at the end will be very fragile and very unstable. When this clot will start to be formed, as we have said, at starting of the endothelial damage, because the collagen will be exposed, and the remaining of the story of the primary homeostasis you should have known already. So the platelets will be part of the primary homeostasis, okay, which is the most, or let's say the main player here, okay. But at the end, the clot is fragile, it's unstable. You need to stabilize this clot, and this stabilization will be by the secondary hemostasis. Sorry, I forgot to say that if you have any question, you can interrupt me anytime. No problem, because I cannot see the chat. Okay, so after formation of this unstable clot or fragile clot, you have to stabilize it by fibrin. You have to stabilize it by fibrin. Okay. And this is secondary hemostasis. Uh, Secondary hemostasis is a very long coagulation cascade. And why we have said that it's a cascade? Because we have many factors, and each one of these factors will cleave the another factor for it to be activated. So it's a cascade. Each factor will activate the next one. And all of them at the start, they are zymogens. And I hope you know what's zymogens. Zymogen are a form of enzyme that is not active. And when it's cleaved by anything, okay, it will be activated, and it will do its function. Okay, so almost all factors are synthesized from the liver except for these three very important factors: factor 3, which is the tissue factor, also known as tissue factor; factor 8, and the 1 Will Brandt factor. And please remember that those two factors always work together. So you have to remember this. Or in a better way, let's say that 1 Will Brandt factor enhances the work or ease the work of the factor 8. And the 1 Will Brandt factor will be explained by the next doctor. So I intentionally put the common pathway at the first. Okay. So how the clot is being formed? We need at the end we need to stabilize the clot by fibrin. So the fibrin is the end product. How fibrin is activated by thrombin. Okay, and how thrombin is activated by factor 10. But how factor 10 is really activated? Okay, now factor 10 is activated by something called the extrinsic pathway. So when there is an endothelial damage, this is at the this is at the beginning. When there's endothelial damage, tissue factor is not in the blood. So it is below the blood vessel or in the layer below the endothelium. So when there's endothelial damage, this tissue factor will be exposed. And here's why we call it extrinsic pathway. It's not in the blood. Tissue factor is not in the blood. So it's an extrinsic pathway. Tissue factor will activate the factor 7, and it will form a complex with it, activating the factor 10. Factor 10 activation will activate the thrombin. But this is not the end of the story, because factor 7, or let's say the extrinsic pathway alone, will not be able to form a lot of fibrin. So we need something called amplification of the pathway. And how this amplification happens? Basically by the thrombin. Yes, by the thrombin. Now, when the extrinsic pathway activates a small amount of thrombin, this small amount of thrombin will go and activate a lot of other factors, because this is a positive feedback. Okay, will activate a lot of other factors, and this activation, يعني, what exactly it will activate? It will activate factor 5, factor 8, factor 9, and factor 11. Okay, please remember these factors. They are very important, especially factor 5 and factor 8, because in the next slide we will also mention them in another concept. So remember, factor 5 and factor 8, they kind of come together. Okay, so thrombin, after being activated by the extrinsic pathway, will go and amplify the whole pathway again, and that will form even more fibrin. Okay, now this is the extrinsic pathway, as we have said, and this is sometimes called the intrinsic pathway, or all of the time it's called intrinsic pathway. But as we have mentioned, the thrombin will go and it will amplify or will activate the factor 11. So the starting of the intrinsic pathway actually is from the 11th factor, not from the 12th, because 12th factor usually is not activated unless in a certain laboratory studies. But it's when it is activated in order to test something, or when you want to test the intrinsic pathway, you activate or you stimulate this factor first. But normally in our body, the start of the pathway is the factor 11. Okay, this is not a very important thing to remember. Just know that a thrombin will amplify the pathway. Okay, now we will come to these things later on. Now this is the whole story. And I want here to highlight some of the very important things. We have already mentioned that fibrin, okay, will be activated by thrombin, that will be activated by factor 10, that is initially activated by factor 7 and tissue factor 3 from the extrinsic pathway. Okay, then the thrombin will amplify the whole pathway again. Okay, and what I want to highlight here is that you can see these stars. Basically, calcium is very important, is very important in the formation of the thrombus. And you will see the importance of this later on, because sometimes when we do laboratory studies, we do basal metabolic panel. One of the reasons, because we want to see the level of the calcium. Okay, because when there's hypocalcemia, there might be a bleeding, because the coagulation process is not enhanced by the calcium. It needs calcium to be fully performed. One more thing here to highlight, as I have said previously, this whole process, you have to be in balance. You have to be in balance. So you cannot let the coagulation process be active all the time. You need something to stop this coagulation. Because once you activate the pathway, you cannot inhibit it unless you activate something else to inhibit it. I mean, if the coagulation cascade still continuous without inhibition, a lot of clots will be formed, and that will be horrible for the body because there will be, uh, as I have said, embolic and thrombotic conditions. Embolic, let's say. Okay. So what we need here, we need something to stop this formation, And here it comes the fibrinolytic system. The fibrinolytic system is very important because it has many therapeutic uses. It's not important. It's not only important in the physiology of the body, but also in the in the some of the therapeutic uses that I will mention. So, what do I mean by fibrinolysis? Fibrinolysis. So, lysing the fibrin. So, when you lyse the fibrin, you kind of stop the coagulation process. How you are going to lyse the fibrin? Basically, you have plasminogen. It's a zymogen as well. Okay, and this plasminogen have to be converted into plasmin, the active form, by the tissue plasminogen activator. Okay, by the tissue plasminogen activator, which sometimes or most of the times get activated by these factors. Okay, sometimes these factors play as a TPA rule. Okay, so let's say when you activate the plasminogen into plasmin by the TPA, you are going to lyse the fibrin, and you are going to stop the coagulation process from being continuous. So this is the balance. Okay, so don't think that all of these things, some of them will be over the other. No, the whole body is in a balance. Okay, so there's no problem in a normal person. Uh, and of course, you don't want another thing, that you don't want the plasma to be always in action. Okay, so we have, because if it is in action all the time, of course it will cause bleeding, because lysing all the thrombus is again not a good thing. Okay, so lysing all the thrombus by the plasmin will cause bleeding. So we need something to stop the continuous action of the plasma, and this is by two very important agents. They are physiologically present in the body: uh, aminocorporic acid and the tranexamic acid. And they are therapeutically used in some way that we will mention. So please remember them. Okay. So the TBAs, what are the indication or therapeutic indication of TBAs? Actually, you have to put in mind that TBAs could be injected or could be given to the patient externally from a synthetic way. Or sometimes they could be extracted from bacteria such as the streptokinase and given to the patient. But what are the indications? Simply speaking, when the patient is in a very severe embolic or thrombotic state, and we want to cleave this thrombus because it might cause ischemia and it might cause organ damage, so we bring this TPA in action. But as I have said, this TPA is very, very dangerous because uh, in certain patients, it could lead to bleeding and it could worsen the condition. Okay, so we don't use it unless it is very, very indicated, and also sometimes even when it is indicated, it's not used. Okay, because of certain risk factors that the patient might have. But the main three indications that I want you to remember. Sorry, this is wrong. Should be ischemic. Okay, the three main indications that I want you to remember in case of ischemia or myocardial infarction, but it is not true all the time. As I have said, we are not going to prefer it over the other things, because STEMIs, if it is possibly treated by the percutaneous intervention, it's fair enough. But sometimes if this percutaneous intervention is not there, we might use TBA. So I want to deliver that these are the indications, but not all the time. Okay, because in certain condition they might cause bleeding, or they might worsen the condition. Also, ischemic stroke. Sorry, not hemorrhagic. Of course, not hemorrhagic. Ischemic stroke also in a certain condition when the patient presents to you within 4.5 hours. Other than this, you are not going to use it. And sometimes even if the patient presents to you within 4 to 4.5 hours, you are not going to use it because of certain risk factors. Okay. The third indication is a massive pulmonary embolism, an embolism that is obstructing the whole trunk. Okay, a massive one. But again, it's not always the case. But these are the main three indications, but not all the time. Okay. So the last slide in the physiology that I want to highlight here is the role of vitamin K in the coagulation. The vitamin K is a procoagulant, enhances the coagulation. The vitamin K in the liver, it is reduced by epoxide reductase in an active form. This active form will activate these 5 factors: factor 2, factor 7, factor 9, factor 10. So 1972. Remember them by 1972. Okay, but not only these 4 factors, you have the factor C and factor S, and this is very, very important to remember, because one of the side effects of warfarin that we will mention later on, it is related to these 2 factors. So remember, please, 1972. There's another number that is somehow close to this number, 1973. This is the number of the parasympathetic cranial nerves. So remember these 2 numbers, they are very important. And also the factor C and factor S. Now these 4 factors, they are also procoagulant. They will enhance the coagulation. But factor C and factor S, they are anticoagulants. So imagine that vitamin K is enhancing the coagulation and also enhancing the anticoagulation at the same time. Okay, so the activated protein C requires protein S to inhibit what? As I have told you previously. Please remember these 2 factors, factor 5 and factor 8, because factor C will inhibit these 2 factors, factor 7, factor 8, and factor 5. Okay, very good. And also in the body, there's autogenous, yes, I think, antithrombin, normally present in the body. Okay, this is another way to inhibit the thrombus formation other than this system. Another way to inhibit the thrombus formation other than the fibrinolytic system. Okay, by the antithrombin 3, and this antithrombin 3 is a target of certain drugs. Okay, certain drugs will activate this antithrombin to inhibit the coagulation, and certain drugs will inhibit this vitamin K activation in order to inhibit the coagulation as well. So this is the whole story. Now it's in your hand. So now I want some of you, or one of you, to read this question and answer it. Anyone, please.
I can read it.
Go ahead.
A 54-year-old woman comes to the emergency department because of sharp chest pain and shortness of breath for 1 day. Her temperature is 57.8 Celsius, pulse is 110 per minute, respiration is 30 per minute, and blood pressure is 87 by 70. CT angiography of the chest shows a large embolus at the right pulmonary artery. Pharmacotherapy with a tissue plasminogen activator is administered. 6 hours later, she developed right-sided weakness and slurred speech. Laboratory studies showed elevated prothrombin and partial thromboplastin time and normal bleeding time. A CT scan of the head shows a large left-sided intracranial hemorrhage. Administration of which of the following is most appropriate to reverse this patient's acquired coagulopathy?
Okay, what do you think, Anwar? What do you think? Yes, please don't see the chat. Give me an answer, please.
Are you asking me?
Huh? What are you saying?
You're asking me?
I'm not. I can't hear you clearly.
I said you're asking me. The question is directed towards me.
Yeah. Yes, answer it, please.
Our answer is E.
Okay, correct. Can you tell me why?
The patient has يعني right-sided weakness and slurred speech. That means that يعني there is bleeding, so we want to stop it basically.
Okay, what is the cause of bleeding? What do you think? Basically, they have used in this patient, they have used the TPA, the tissue plasminogen activator. And I have told you it's not should always be used. Why it is used here? Because of the pulmonary embolism. They considered it as an indication and they have used the TPA. And they have told you TPA is not always should be used. Okay? Even though it's a large impulse at the right pulmonary artery. Even though it is indicated, it's really indicated here, but it will cause its side effect is a very massive bleeding, specifically in the brain. So the TPA result in bleeding, this is this يعني we cannot stop the bleeding. يعني really we cannot stop the bleeding actually, but we will try. So usually we support the patient and we try to stop the bleeding by the amino corporic acid or tranexamic acid, as I have told you earlier here. The TPA could be inhibited by the amino corporic acid and the tranexamic acid. And these two things, by inhibiting the TPA, they will stabilize the clot even more. Okay, they will inhibit the inhibition. They will inhibit the block, or let's say the destruction of the clot. I hope it's clear. Okay, uh, now going to the bleeding disorders. Now, how to approach a bleeding disorder? How to approach a bleeding disorder? Basically, uh, you have to imagine that a patient will come to you with the symptoms. A patient will come to you with a clinical picture, and you have to take history from this patient. Okay. Now, when we say a bleeding disorder, we either when we say bleeding disorder, we yani bleeding when patient come with the bleeding symptoms, as as of these symptoms, as we will explain, you have to think of either of two categories. It could be a primary hemostasis disorder or a secondary hemostasis disorder, and you have to be able to differentiate between them clinically. But of course, clinical differentiation will not be enough. So you have to go for initial and advanced laboratory testing. So primary hemostasis disorders is when the problem is in the platelet. And I believe it has been described earlier. What are the bleeding problems? Okay, what are the bleeding problems that are related to platelets? Now, my job is to explain these to you. But of course, you have to be able to differentiate between the bleeding that is because of the coagulation factors and the bleeding that is because of the platelets. Because of course, the management will be totally different. Okay, so you will have to take the clinical picture from the patient. You have to notice all the clinical signs, clinical symptoms, and you have to take history from the patient. And I will mention the important part of the history that you have to ask about. Okay, and you have to do physical examination. Now here the physical examination usually is inspection. You have to inspect for any bleeding. Okay, usually in the skin, of course, in the skin, in the mucosa, and in the joints. Now usually when a platelet is dysfunctioned or when there is a problem in a platelet due to anything, due to drug use, due to immune condition, due to anything, usually the bleeding will be superficial. What do I mean by superficial bleeding? I mean there will be no internal bleeding in the there will not be, for example, bleeding in the liver itself or bleeding uh, in the joints. So there will be no internal bleeding, but external bleeding or superficial bleeding. Superficial bleeding is a better term. Okay, superficial bleeding. So what are the superficial bleeding signs that you could see? Epistaxis, bleeding from the nose, bleeding from the gums, gastrointestinal bleeding, melena or hematochezia. Okay, uh, and also cutaneous, subcutaneous bleeding such as petechia and porpora. What is petechia? Petechia basically it is a non-palpable, yani red dot, non-palpable, very small red dot in the skin. Porpora it's also non-palpable, a red dot, red, but it is more than a dot. Okay, it is large. Yani it is covering more area than the petechia. So petechia is non-palpable, and non-palpable lesion in the skin we call it macule. Okay, palpable lesion in the skin we call it papule or nodule. Okay, so it's a non-palpable macule, but it's very small. This one is also non-palpable macule, but it is larger. Okay, superficial ecchymosis. they are palpable. Here they are palpable, easy bruising. But still, they are all of these things. They are superficial, and they will show you that there's a superficial bleeding, and they will show you most of the time that this problem is in the platelet. Okay. Now, in the opposite way, when the problem is in the coagulation factors, the bleeding will be deep. There will be deep bleeding, and even uh, let's say, I will not say more severe, but it will appear as a more severe bleeding. Okay, especially there will be very large palpable ecchymosis. They are very large. Okay, beside hematomas is similar. Hematoma. What is the difference between hematoma and ecchymosis? Hematoma usually occur after trauma, but ecchymosis sometimes could occur even without trauma. Okay, but most of them they describe similar thing. Okay, or it could be hemarthrosis. Okay, hemarthrosis is a blood in the joints, usually in the knee, but it could be anywhere else, in the ankle, in the elbow, in the wrist. So you have to take the clinical picture. You have to be very, very, very careful. Okay, because clinical picture will direct you toward or will give you a clue about this thing. So take home message: problem in the platelets, superficial bleeding. Problem in the coagulation factors or secondary, it will be deep tissue bleeding. Okay. Now, after taking the the clinical picture, the history, and the physical examination, you have to go for laboratory. Okay, so the laboratory is indicated when there is a symptoms, of course, when there is a family history. What I mean by family history, that one of his family has similar condition. Okay, and if there's a chronic illnesses as well, as we have said, liver will synthesize most of the coagulation factor, and it also contributes to the formation of platelet by thrombopoietin. Similarly, the kidney. Okay, so chronic illnesses also might cause bleeding. Okay, or autoimmune condition as well. Okay, and any use of medication, you have to take the history of medications use, because if the patient is on anticoagulants or antiplatelets, then the whole story is kind of justified. Okay, or when the patient is on medication that inhibit the platelet function or decrease the platelet activity or count, such as NSAIDs, nitrate, and chemotherapy, also you have to think about going to laboratory testing. Okay, so what are the laboratory testings? Basically, you have initial and advanced laboratory testing. So you are going to order, yeah, kind of you are going to order all of these things to the patient. Okay, you have to order the CBC. What is the importance of the CBC? Complete blood count. You have to know you need to know, okay, or you need to know the number of the platelets. If the platelet count is decreased, then half of the story is justified. Okay, and of course the number of other cells, because it might give you a clue about the diagnosis. Okay, basal metabolic panel, as we have discussed earlier, it might show you a problem in the calcium or any other, um, let's say, electrolyte that is contributing to the coagulation. Liver, as we have said, we have to take the liver function test, because if there's acute problem in the liver, the liver enzyme might be elevated, and that might cause a coagulation problem, because when the liver is not healthy, it will not go, it is not going, or it will not synthesize the factors. It will not perform its normal function. Okay. Uh, Now they will use peripheral blood smear, but forget about this now. Now my aim here is to explain the coagulation panel, and the bleeding time as well. I think bleeding time has already been explained, but we will go through it quickly. So basically, you'll order these things beside the coagulation panel. The most useful thing here is the coagulation panel and the bleeding time initially. So these all are initial laboratory studies. So in the question, if you are asked about initial things, don't use a very definitive measures. These measures, they will not diagnose the patient. Okay, they will only give you a clue. Okay, and after this, you are going to go for more advanced studies that will actually diagnose the patient. So regarding the coagulation panel, okay, I will describe them firstly, and then I will give you the concept and how they are really done. Okay, So we have PTT, PT, INR, and BT. Okay. Now the PTT, or the partial thromboplastin time, forget about the name, or forget about the only remember the abbreviation. This study is used to test the intrinsic pathway. Okay, its importance is testing the intrinsic pathway. It's also test the common pathway, but it is not. This is not really the aim. The aim is the intrinsic pathway. So when there is a problem in the PTT, okay, or when the PTT is prolonged, immediately you have to think about one of these intrinsic factors: factor 12, factor 11, factor 9, factor 8. Okay, but when there is a problem in the PT, okay, here you are going to test the extrinsic pathway. So you are going to think either it is a tissue factor or factor 7. Okay, so very important thing to remember here, that PTT will tell you about the intrinsic pathway, but PT will tell you about the extrinsic pathway. How to remember this? Basically, PTT, okay, play table tennis. Playing table tennis is usually, or table tennis is usually an indoor activity. Okay, it's an indoor activity. So remember that it is an intrinsic pathway. But PT, or play tennis, only tennis, but without the table, it is an outdoor activity. So remember that it is extrinsic. It will tell you about the extrinsic pathway. Okay, so how we really do these things? Okay, because here it's written that the normal range is between 11 to 15 seconds, and here is the normal range is between 25 to 40 seconds. And of course you have to remember these two ranges. How we are going to do this test? Basically, in the prothrombin time, we will take the patient plasma. We will take the patient plasma, sorry, and we will add a tissue factor to it. Now, adding the tissue factor to the plasma will activate the factor 7, and activating the factor 7 will activate the common pathway, and that will lead to coagulation. So in normal person, we expect this process to be to happen in a certain period of time. For example, we expect it to happen in a 10 seconds. But if this coagulation happens in more than 10 seconds, in 11 to 15, or more than 15, let's say, because here it's written more than 15, okay? If the coagulation uh, coagulation does not happen until more than 15 seconds, we are going to expect that, okay, there is a problem in the activation here. There's tissue factor is not activating the factor 7, or factor 7 is not there to be activated. So there is a problem. There is a delay in the coagulation, okay? Or we can say there is a bleeding, okay? So this is the concept. We expect the normal patient coagulation to happen in a certain time. So when there's a prolongation, of this timing of this range, we expect that this patient is prone to bleeding due to certain thing. The INR, or the international normalized ratio, is basically the patient PT divided by the control PT. The control PT, which is the normal one, okay, or the normal PT for all the people, okay, which is between 11 to 15. Patient PT, it could be either high or low. So the ratio that we will get will tell us whether the patient is prone to bleeding or prone to coagulation. Okay. For example, if the patient PT is very high, meaning that the patient is not forming a clot in a short time, meaning that the patient is prone to bleeding. Okay, so a ratio of more than 1, meaning that the patient is at risk of bleeding. But a ratio of less than 1, meaning that the a ratio of less than 1 will mean the opposite, that the patient is prone to clot formation. I hope it is clear. Okay, now these two are used for the extrinsic pathway. Remember, play tennis. Tennis is outdoor. The PTT is used for the intrinsic pathway. It's activated similarly. So we take the plasma, but we don't mix it with tissue factor. We mix it with another substance, negatively charged substance called silica, and this will cause the formation of the clot, usually in a 30 seconds, okay, or between 25 to 40 seconds. There's prolongation. There's prolongation to this time or if there's delay, that will mean that the patient is not forming the clot in the normal time, that the patient, meaning that the patient is prone to bleeding. Okay, so here you are going to think of one of these factors. Okay, one of these factors to be the problem. Okay, the intrinsic factors, and usually it might be factor 8 or factor 9 most of the times. Okay, now this is the initial testing. Okay, of course we will not forget about the bleeding time. Bleeding time. We have discussed PTT, PT, and INR. What about bleeding time? Bleeding time will show you the function of the platelets. The function of the platelets. Basically, you are going to you are going to make a small puncture to the skin. Okay, so you're going to injure the patient in a very small or gentle way, and the patient should clot within 2 to 7 minutes. Okay, that will tell you about the platelet function. If this timing is delayed, for example, if the patient clot formed in 9 minutes, 8 minutes, 10 minutes, this is a delay. So the patient is platelet are not normal. Okay, or there might be something else not normal, as you will see in the von Willebrand disease. Okay, because von Willebrand factor interfere in the platelet function and in the coagulation function. So I hope the initial laboratory studies are very, very clear. Okay, I'm not going to describe everything here. Just know that the disorder in the primary hemostasis or in the platelets will cause a problem in the platelet measure. So platelet count might be low, and the bleeding time, of course, will be high. Why high? Because being high, meaning that there's bleeding going on. Okay, or the platelet count might be normal and the bleeding time might be high. But in secondary hemostasis problem, when the problem is in the coagulation factors, the problem will be either in the PTT or in the either in the PT INR or in the PTT or in both of them. Okay, as you will see. Okay, now that will not be enough. The initial testing will not be enough. So we started by talking about the clinical picture. Then we have gone through the initial laboratory studies, and then you have to go for the advanced studies because it's not enough. Okay, when you for example know that the problem is in the intrinsic pathway or in the extrinsic pathway, you still want to know which factor exactly is the problem. Okay, because you want to replace this factor, you want to treat this patient by giving a replacement. Okay, so there is two important things here to be thought about. Okay, there's something called factors assay. So each factor will have an assay, will have a certain test for it. You can do it. There is also a mixing study. Okay, I will explain both of them in the next slide, but please remember that the advanced studies are factor assays and mixing study. Now, these two are for the secondary hemostasis problem. Okay, but in a primary hemostasis problem, the advanced study will be different. Will be different. But here, because we are talking about secondary hemostasis, so I didn't bring out the advanced laboratory studies of the primary one. Okay, so please remember the factor assays and the mixing study. I will explain both of them later on. But these two are the advanced studies, or let's say the confirmatory ones. The previously mentioned one are the initial ones. Okay. Now I will explain them here. We have the hemophilia. Now, hemophilia is uh, one of the coagulation disorders. Okay. Uh, is it a coagulopathy or thrombophilia? It is a coagulopathy. It's not a thrombophilia. Don't be confused. Don't confuse yourself by the that hemophilia is similar to thrombophilia, so there's a thrombus formation. No, no, it's not the case. It's not the case here. Hemophilia means uh, it's it, it's part of the it is part of the coagulopathy problem. So there is a problem in the formation of the clot. So there is a bleeding. Okay? It's not thrombophilia. Okay, this is very important to understand. Okay, how to diagnose it? Sorry, there should be a slide before this telling about the clinical picture, but no problem. I will tell you about them. Now, basically, hemophilia, the patient will come to you, okay, will come to you with a bleeding initially, or the most important word or the key word in the hemophilia is that the patient will come to you with intra-articular bleeding or joint bleeding or hemarthrosis. Okay, please remember this. This is the most important thing in hemophilia. The patient will come to you with hemarthrosis, but when that will happen, okay, the patient, remember that the patient will present to you either in childhood or in adulthood or in adolescence. Sorry, it will not be a very late presentation, because if the patient is having hemophilia, okay, the patient will present very early, because why? Because it's a genetic condition. Because it's a genetic condition. It's an X-linked recessive condition. Okay, it's either hemophilia A. I'm not sure if this is shown, but it's either hemophilia A, that the problem is in the factor 8, or it's hemophilia P, the problem in factor 9. Okay, so there's no, the coagulation process is kind of not going well. Okay, so because it's an X-linked recessive condition, you can imagine that the patient that will present to you, most of them will be male. Usually, female will not come to you with hemophilia unless she has the both of her genes defective, because it is a recessive. Okay, and the female has two X's. Females have two X's. So one of the them being affected is not enough for the female to have the disease, but for the male they have XY. So one of the so there's no another X copy to let's say to compensate. So only the problem only in the X in the male will be enough to manifest the disease. So most of the patients will be males. Okay, and they will come early in life with a internal bleeding. I'm not saying that there will not be superficial bleeding. Please understand this. I am not saying that there will be no superficial bleeding. There might be gum bleeding, there might be mucosal bleeding, or ecchymosis, or but usually there is no petechia. Okay, yeah, I mean there might be other symptoms, but the most important thing is the uh, in hemarthrosis. And if the patient comes to you with hemarthrosis, you have to go for initially the initial thing. Of course, you have to go for the initial testing, as we have told you. Okay, you have to go with for the coagulation panel. Okay, after going for the coagulation panel, mostly because the patient is having problem in either one of these two, either factor 8 or factor 9, and we know that both of these factors are in the intrinsic pathway. So usually the PT, or the prothrombin time, or the plateletness study will be normal, but the plateletness study, which is the indoor activity, which is the intrinsic pathway, okay, it will be prolonged. So when you see that there is a prolongation in the PTT, the next thing to do is a mixing study. Okay, what is mixing study? I will explain it after explaining the assay study. Okay, so park the mixing study. So after the PTT, the first thing to go to is the mixing study. Now let's suppose that we have done a mixing study, and that suggests us to go for an assay study. This is the confirmatory study. Now, in assay study, the concept or the process itself is somehow complex. So only understand that you are going to measure the activity of a certain factors in the patient plasma. You are going to measure by a certain way. You are going to measure the patient activity of factor 8 and factor 9. And if this activity is below 40% of the normal, okay, you are going to consider it as hemophilia. Okay, is this enough? Okay, unfortunately, it's not enough. Okay, I will tell you why. But this is a confirmatory, but it's still not enough. Okay, so as I have said, after going for the PTT being prolonged, you are going to go for a mixing study, and I will explain it later. Let's say that the mixing study has suggested you to go for a certain factor assay, and you have gone for a factor 8 and factor 9 assay, and they have shown a decrease in the activity level below than 40%. Okay, now you are kind of almost have reached the diagnosis to be hemophilia, either A or B. Okay, but still you want to exclude one thing. You want to exclude a von Willebrand problem, because I have told you, von Willebrand problem might cause a factor VIII problem because they are both coupled together. So before diagnosing the patient to be 100%, you're saying that the patient is suffering from hemophilia, you have to exclude that the patient is having Manuel-Brand disease. Okay, you have to exclude this by an antigen test or another test that will be explained later. Okay, so I hope it is clear. So PTT, prolonged initial studying, then go for advanced studying, mixing, and then the normal, or let's say the factor assay. Like, what about the mixing study and why we do this mixing study? Now, basically, we want to differentiate between two things. We want to differentiate between the hemophilia. Is it acquired or congenital? The congenital hemophilia is this one, the X-linked recessive one. Okay, there's acquired hemophilia. What is the acquired hemophilia? Basically, the acquired hemophilia is that because of the patient has gone through malignancy or has gone through child giving birth or another factor, patient might form IgG immunoglobulins against the coagulation factors, and unfortunately, most of the time it's against the factor VIII, so it will present as prolongation of PTT. So how to differentiate between an acquired cause and a coagulation cause and a congenital cause? Basically, you have to go for the mixing study to differentiate between the congenital and the acquired condition. So what you are going to do, basically, you will have the patient blood, and then you will mix it with another blood, which is the normal plasma. Okay, you have the normal plasma, and you have the patient plasma. So let's suppose that this patient is having hemophilia A, which is the congenital one. So hemophilia A, there will be no factor VIII. Okay, so when you mix the patient plasma, which is deprived or depleted of factor VIII, with a normal plasma, which is full of factor VIII, usually the PTT will be corrected. Okay, so here in this patient, you have a prolonged PTT because of the problem of the factor VIII. But when you mix this plasma, this factor VIII depleted plasma with a normal plasma full of factor VIII, the PTT will be corrected. Okay, this is what. So if in the mixing study, the PTT is corrected, then immediately go for the factor, special factor assay. But if there is a anti or immunoglobulin in patient with acquired coagulation, as we have said. Why it's acquired hemophilia? Because there is a newly formed IgGs or immunoglobulins against factor VIII or another factor. So these immunoglobulins are inhibiting factor VIII. So they are causing increasing prolongation of the PTT, similar to the hemophilia. So how to differentiate between them? We are going to bring a normal plasma, okay, with the patient or with patient plasma, which is full of IgGs. Okay, and if we mix them all together, the PTT will not be corrected because there is still an inhibitors that will inhibit the patient on factor VIII and also the normal plasma factor VIII. Okay, so the PTT will not be corrected. Okay, this is the concept. Why? Because of the presence of the immunoglobulins anyway. They are anyway present. They are all the time will inhibit the factor VIII, whether you mix them, whether you don't mix them, the PTT will not be corrected. So after the mixing study, if the PTT is not corrected, go for a total another workup, and we are not going to go through it. But if the PTT is corrected, then go for the factor assay, and then the rest of the story is with you. Okay, so how to treat the hemophilia? Basically, you have to understand that we can treat them with a replacement factor. It's very easy to understand. Hemophilia patients might be factor VIII depleted or factor IX depleted. Okay, so we might give replacement, but are we going to give replacement all the time? Not really. Why? Because if you are going to give replacement all the time, this will cause downregulation, or let's say will cause desensitization of the factors. Or in another word, that might that might lead to a formation of antibodies against these factors, leading to any inadequate response, basically. So we are not going to give them all the time. Okay, there's a certain indications where we give these factors because the patient will not be bleeding all the time. Okay, this is another thing to understand. The patient will not be bleeding all the time. He will be at risk of bleeding. So we will expect when this patient will be at risk, and we will give the replacement. Simple as this. Okay. So when the patient is under acute or severe bleeding, of course, give replacement. Before surgery, before urgent or emergent surgery, of course, give replacement because the patient will be cut by a certain instrument, and that might cause severe bleeding if not replaced, or in a certain elective surgery. So you have these three categories of the hemophilia. Usually, in mild hemophilia, we don't treat actually because the patient will not have hematomas or bleeding unless he is very severely traumatized. And when he is very severely traumatized, we are going to manage by the replacement. Okay, moderate hemophilia, similar thing. Severe hemophilia, the patient will be bleeding all the time, so he will be here. So you are going to give the replacement. There are another alternatives, or there is another choices, desmopressin and the amino carboxylic or tranexamic acid. Now, desmopressin, okay, it is analog antidiuretic hormone. So you might ask how antidiuretic hormone, which is usually functioning in a way that that is causing water retention at the kidney, how it is really causing hemophilia to be corrected. Basically, because the antidiuretic hormone has another secondary function. It could basically release more vulnerable factor from the endothelial cells. And as we have said, vulnerable is coupled to factor 8. So releasing more vulnerable might lead to formation of more factor 8. Okay, so this is the concept. Again, you are not going to use it all the time because of the same concept. Because of in a prolonged use, there will be diminishing response. Okay, very good. What are the side effects? Hyponatremia. Why hyponatremia? Basically, because it is an antidiuretic hormone at the end, so there will be water retention. So water retention will decrease the osmolarity, and that will cause hyponatremia. And you have to know the how hyponatremia will manifest in order to know whether there's hyponatremia or not. So the patient will not come to you with hyponatremia. The patient will come to you with hyponatremia manifestation. Okay, so usually hyponatremia uh, usually will manifest with a neurological problem. Okay, maybe headache. So headache is here. Maybe seizures or certain concussion, not concussions, let's say convulsions. Yeah. So you have to expect hyponatremia and you have to correct it immediately. Okay. Now, the third choice is the amino caproic acid and the tranexamic acid. As we have said earlier in the start of the discussion, sorry, yes, that both of these two, they inhibit the tissue plasminogen activator. Okay, by inhibiting these things, by inhibiting this agent, there will be stabilization of the fibrin. The fibrin will not be inhibited, so the clot will be stabilized. So we might give them in a case of hemophilia. Okay, so we have seen their use to antagonize the TBA earlier, but also we might use them to treat hemophilia. Okay, yes. So they will inhibit the formation of plasma, as we have said, when they are useful. When the patient is on mild hemophilia or in moderate hemophilia, when there is leading to mild trauma, or when there is no hematomas but very superficial bleeding, because as we have said, hemophilia patient will not only be having hemarthrosis, patient will be having another things. Okay, the patient could have the superficial bleeding. It's not a must. It's not a fully strict clinical picture, but the patient at the end will come to you with hemarthrosis or at least history of hemarthrosis. Okay, to differentiate it between the primary hemostasis disorder. But remember that also when the patients come to you with these things or with superficial bleeding, that does not exclude hemophilia. And this is why we go for initial laboratory studies and then we go for the advanced laboratory studies. Okay. A question. Who will answer? Please, any one of you could read and answer. It's a very easy question. We're almost done. Yes, please. Okay, I will choose one of you. Abdularis, please read that answer. Mhm. Okay, so no one is responding. So a 3-year-old boy is brought to the emergency department because of pain and swelling of his right knee joint for 1 day. Okay, hasn't had any trauma to the knee. This is a very important thing. He was born at term and has been healthy since he was born. His maternal uncle has a history of bleeding disorder. His temperature is 37, pulse is 97. The right knee is erythematous, swollen, and tender. Range of motion is limited. No other joints are affected. X-ray is not important. Ultracentesis is done. The synovial fluid is bloody. Further evaluation of the patient is most likely to show which of the following findings. So anyone could open the mic and answer, please. Please, please, please use your answer.
I think it's E, prolonged prothrombin time.
Yes, yes, of course, it's E. Please respond immediately, please, guys. Don't make me wait that much. Okay, so the important point here are the patient is presenting early in life. He's a 3-year-old boy. Okay, and he is having a joint swelling, and this swelling has been proven to be bloody. So this is a hemoarthrosis. Okay, and there's a history of his ankle to also have the same problem. So this is a very classical picture of hemophilia. Okay, and hemophilia is a prolonged prothrombin time. Okay, or it will have prolonged prothrombin time. So finally, I will talk about part of the anticoagulation, and then Lean will complete. Okay, I will talk about warfarin and heparin. Okay, now warfarin is an anticoagulant drug. Okay, what does anticoagulation mean? It is uh, opposing the coagulation. So we want less coagulation. So we want less clot formation. Okay, so warfarin is used to decrease the clot formation. Okay, I hope warfarin is used to decrease the clot formation in cases where the patient is undergoing a higher amount of clot formation. Okay, I hope it's clear. So how warfarin will act? Before talking about this, warfarin is an oral agent, so it's easily given orally. Okay, in reverse to heparin, which is given either subcutaneously or intravenously. Okay, this is an important thing to know. So warfarin basically will inhibit the action of the vitamin K, and we have already known that vitamin K has a role in the activation of these 4 factors. Okay, so specifically, it will inhibit the vitamin K epoxide reductase. Okay, remember this for your USMLE exam if you are going to take one. Okay, so basically inhibiting this enzyme will inhibit the reduction of vitamin K, and that will inhibit the carboxylation of these factors. So these factors will not be activated. Okay, now what is the clinical use of warfarin? Basically, you have to think about things uh, that making the patient making a lot of thrombus or a lot of clots. Venous thromboembolism, either you are talking about uh, uh, DVT or pulmonary embolism, but I will tell you what is the difference when to use warfarin and when to use heparin. Sometimes you use them both, okay, as a prophylaxis, and also for stroke prevention in atrial fibrillation. Why we want to prevent stroke in atrial fibrillation? Because basically atrial fibrillation will cause a stasis in the left atrium, and this stasis, okay, will lead to thrombus formation. This thrombus might be dislodged, and when this thrombus is dislodged, that will cause a stroke. Okay, so warfarin could inhibit or could prevent this easily. But warfarin at the end, it is not used in pregnancy. It is because it's teratogenic, and we have to monitor the warfarin regularly. Okay, now how we will monitor warfarin? We will monitor warfarin the same way we monitor the extrinsic pathway. We monitor it by the PT and the INR. Okay, please remember this. This is a very high information that we monitor the warfarin similar to the way that we monitor the extrinsic pathway by PT and by NR. Okay. Now the ideal INR usually by INR. Okay, usually by INR. As we have said, normal INR is 1. Okay, but in warfarin, the target INR is not 1. Our threshold will increase because you are taking warfarin, and the patient INR anyway will increase. Okay, so our target in the patient taking warfarin, our target INR will be between 2 and 3. Remember this. This is a very high information. When the INR is more than 3, the patient will be on bleeding. Okay, it will suffer from bleeding. So this is our target, between 2 and 3. You might ask me why between 2 and 3. This is an evidence-based information. Okay, this is an evidence-based in medicine. They have done many studies, many researches. It shows that patient taking warfarin, when they are in this range, they are very less prone to complications. Okay, so this is our target. So patient with warfarin is very prone to bleeding, not used in pregnancy because it's teratogenic, and it is full of drug-drug interaction. And there is something here very important called skin tissue necrosis. What is skin tissue necrosis? Now, when we go back to this figure, okay, when we go back to this figure, you see that warfarin will inhibit the formation or the activation of these 6 factors. Okay, these 2 factors are anticoagulants, but these the 4 factors are procoagulants. Now the problem here is that the half-life of these 2 factors is much shorter than the half-life of these 4 factors. So when you use warfarin inhibiting the vitamin K, these 2 factors will be depleted even much before the depletion of these factors. So the patient will be on transient hypercoagulable state. Although he is taking warfarin, but the patient will be in a transient hypercoagulable state because these 2 factors are of short half-life. Okay, so the patient might go in a very severe microthrombus formation. And this microthrombus formation usually could be in the skin or any tissue. And so we call it skin tissue necrosis because it might lead to necrosis. So how to prevent this? Always, when you use warfarin, use heparin with it. Okay, because heparin will prevent this. Because heparin will act on factor 2 and factor 10, one of the 2 factors that are inhibited by warfarin. So kind of the heparin will inhibit these factors at the same time of inhibition of protein C and S, so there will be no skin to tissue necrosis. So always remember, using warfarin will not be alone. Always you use heparin with warfarin, and then you will discontinue the heparin. Okay, still you will still be using the warfarin, and you will be always monitoring it regularly. But what if the patient come to you with a bleeding, very active bleeding, and you have discovered in the history that the patient is taking warfarin? As we have said, part of the approach, our approach history. So you might discover that the patient is on warfarin. So this bleeding might be due to warfarin. So how to reverse this bleeding? If you want a very rapid reversal, use either one of these 2, the fresh plasma or the prothrombin complex concentrate. Okay, it's basically both of these 2 will have the coagulation factors that usually warfarin inhibit. So the bleeding will be corrected immediately. But if you don't want a very rapid reversal, you might use the vitamin K. Or sometimes we use them both in order to maintain a very rapid reverse. And also because this is a rapid, we also want a very tamed reversal. So we might use vitamin K at the same time.
Excuse me,
I know
Faisal?
this. Yes, please.
Sorry for interrupting. Just regarding the vitamin K point, can we say it's better to use the vitamin K for reversal because it isn't very rapid, or we prefer the FFP or the PCC?
When the patient come to you, with a very profound active bleeding, of course you have to use the fresh frozen plasma or the prothrombin concentrate. This will maintain a very rapid reversal of the problem. But you want also, these two will not, let's say, will not act in a very long-term way. They will reverse the bleeding, but when their action is gone, the bleeding will go back. So we will use vitamin K with it. So the best way is to use all of these three things. But if the
Both of
question,
them.
yeah, but if the question states that you want a rapid reversal, of course you have to choose one of these two as initial thing.
Thank you.
Okay,
It's very
you are welcome. Okay, so for the drug-drug interaction, of course you don't have to remember all of these things. Uh, but if you are planning for USMLE exam, you have to remember all of them. Okay, but for course importance, please remember that warfarin is full of drug-drug interaction. Warfarin is metabolized by cytochrome B450. This enzyme is in the liver. So when this enzyme could be altered or could be regulated in many ways. If you take warfarin with another drug, the another drug might either induce or inhibit this enzyme. So what will happen if we inhibit or induce this enzyme? Just imagine that you are inhibiting this enzyme. Inhibiting this enzyme will not will lead to warfarin action prolongation. So the warfarin will stay in the blood more. Okay. So again, when you inhibit this enzyme by these inhibitors, okay, the action of warfarin will stay in the blood. It will stay for a longer time. So that might cause bleeding. So using of warfarin with any one of these might cause bleeding. And please remember the things that I have circled. Remember that usually the GERD treatment, PPI, and the H2 blockers, once they are used with warfarin, they might cause bleeding. And also remember the antibiotics, some of the antibiotics, chloramphenicol, erythromycin, sulfonamide, ciprofloxacin, and also some of the antifungal. These, when they are given with warfarin, they will cause cytochrome B450 inhibition, so warfarin action prolongation. But the opposite will happen when you use inducers. When you use inducers, you will induce the action of cytochrome B450, so you will induce the conversion of warfarin or the metabolization of warfarin. So you will kind of decrease the action. So that might cause coagulation, the reverse of bleeding. And please remember, you have here 4 antibiotics, but one of the antibiotics, rifampin, the RNA polymerase inhibitor, it will be inducer. And most of the anti-epileptic drugs, phenytoin, phenobarbital, and carbamazepine, are inducers as well, except for the valproate. Okay. Last but not least, as we have said, warfarin is monitored by INR, and the target INR is 2 to 3. So when you monitor the INR and you see that the INR is not in the target, what to do? Basically, if the INR is below than 4.5, but still there's no bleeding, okay? So the patient comes to you for a regular monitoring, and you have taken the INR, or you have done the INR formula, and you have seen that it is not in the target, but it is still less than 4.5. So basically, hold the dose, don't give the next dose, and readjust the dose. You might decrease the dose only, okay? But not give the next dose and decrease the dose. But what if the INR is between 4.5 and 10, still without bleeding? Here you have to go. Here you have to hold warfarin temporarily for a few doses, not for only one dose, and also you have to administer vitamin K. So here is Anwar, one of the indication that you might give vitamin K alone, okay, without the fresh frozen plasma and the prothrombin complex concentrate. But what if the INR is more than 10? Here, just continue warfarin, okay, and give the oral vitamin K and monitor it regularly. So similar to this one, okay, but here you are going to hold it for a few doses. Here you are going to discontinue it, okay? So please remember this. You might be asked about this in the exam. what if there is bleeding, regardless of the INR value? If there is bleeding, discontinue warfarin and give everything, as I have told you. Okay, what about the heparin? The heparin, basically, as we have said, it's used for bridging with warfarin. How heparin is used? Basically, it is given intravenously or subcutaneously. Okay, is activate the antithrombin. We have said that antithrombin is an endogenous product or endogenous agent that usually inhibit factor 2 and factor 10. So activating this antithrombin by heparin will lead to the inhibition of factor 2 and factor 10. Okay, but because if it's a shorter half-life and of more immediate, more rapid action than warfarin, we give it for immediate problems. We might give it IV in cases of MI. We might give it also IV in case of pulmonary embolism. So immediate anticoagulation. Similarly, we give it first in the DVT. We give it with warfarin usually, and then we keep the patient on warfarin, okay, because of the bridging concept, as I have told you. What are the adverse effects of heparin? Now, usually, please remember that heparin could come in two forms: either unfractionated heparin, which is when you told that you are using heparin, usually this is the unfractionated or the whole molecular weight heparin. Okay. But you could sometimes extract part of this whole molecular weight and make it smaller, only use the active part. This is what we are calling low molecular weight heparin, enoxaparin and deltaparin. The heparin itself should be monitored with PTT. So it's similar way that we used to monitor the intrinsic pathway, okay? Because heparin could cause also bleeding, okay? So you have to monitor. But the low molecular weight heparin is very safe to the extent that we don't need to use a monitoring for it. And even safer than the heparin in causing hit, in causing bleeding, in causing osteoporosis. I think it has been explained, so no need to go through it. Okay. This is a comparison. You can read it by its own. But here you have to know that the heparin is antagonized by the protamine sulfate, while the warfarin by vitamin T, rich frozen plasma, and prothrombin concentrate. Okay, last question. Last question, please, any one of you.
Can I?
Go ahead, yes, please.
Okay, can you hear me?
Yes, it's very good.
A 26-year-old man comes to the physician because of two-week history of easy bruising. He had myocardial infarction 1 year ago. He also has hypertension, gastroesophageal reflux disease, atrial fibrillation, tinnitus, and osteopenia. He reports that 3 weeks ago he had an appointment with his gastrointestinologist, enterologist. Current medication include warfarin, lisinopril, omeprazole, atorvastatin. He changed his diet after his myocardial infarction to include more green leafy vegetables. He drinks 4 to 5 large cups of coffee per day. He smokes a half pack of cigarettes daily, but does not drink any alcohol. His vital signs are within normal limits. Physical examination shows diffuse ecchymosis along his forearms bilaterally. Which of the following is most likely cause of this patient's symptoms?
What do you think, Abdulhab? So there's something interacting with the patient offering.
It will be impossible.
Yes, of course. Thank you very much. As we have told you earlier, that omeprazole will inhibit cytochrome or any GERD. Please remember, any GERD drug, either cimetidine, H2 blocker, or omeprazole PPI, any other agent of PPI, will inhibit the cytochrome B450, and that will that will reduce the metabolization of warfarin, increasing the warfarin activity, so causing bleeding. And here the bleeding of the patient come in a form of ecchymosis. Where it is, yes, it was an ecchymosis. Okay, so that's it for me, and thank you very much for listening. And I will leave you with Lean. Sorry, Lean, for the delay, and go ahead, please.
Thank you very much, Faisal.
You are welcome.
اوكي صوتي واضح؟
واضح لين.
Yes, clear. تمام. Okay. السلام عليكم. I'm لين الجاجة, and I'm going to discuss another anticoagulant. So here we have another class which is direct factor inhibitors. And from the name, it's a direct inhibitor for a specific coagulation factor. So it will inhibit a specific factor. And we have two of them. So we have direct thrombin inhibitor and we have direct factor 10 inhibitor. For the direct thrombin inhibitor, it will inhibit the thrombin factor. And here we have some examples, and you can remember them from the first letters. So they can make a mnemonic, which is bad, the word bad. Okay, so for the mechanism of action, as the name tells, it's a direct inhibitor. And direct for what? For the thrombin, which is the factor 2. Also, it can inhibit the thrombin even if it's soluble in the blood, free, soluble in the blood, or if it's with a clot. And we have an exception here and an extra function of one of them, which is bivalirudin. It inhibits the platelet activation. So they use it in combination with aspirin during percutaneous coronary angioplasty. So the mechanism of action of direct thrombin inhibitor, it's to directly inhibit the thrombin, soluble or with a clot. And we have an extra function, which is bivalirudin inhibit the platelet activation. For the clinical use in the coagulation, like the venous thromboembolism, atrial fibrillation, and also it's used in the heparin-induced thrombocytopenia, because sometimes heparin lead to thrombocytopenia or decrease in the platelet count. So we can use it as an alternative for the heparin. Also, one of them, which is dabigatran, is the only one that is given orally. Okay, for the adverse effect, it's an anticoagulant. So of course, it can lead to bleeding. And to stop this bleeding or to reverse this bleeding or to treat this bleeding, we can use an antibody, which is monoclonal antibody humanized. So it's made from the human. It's idarosuzumab. Okay. Also, we have here some notes that it doesn't interact with B45. So there is no interacting with a drug or drug-drug interaction. Also, it doesn't require lab monitoring, not like warfarin or heparin. And these two considered like an advantages. So direct thrombin inhibitor inhibit the thrombin, can be used in the heparin-induced thrombocytopenia. It doesn't have drug-drug interaction, doesn't require lab monitoring, and we can reverse its adverse effect by adrenocizumab. The second one, it's direct factor 10 inhibitor. So it will, from the name, it will inhibit factor 10. And we have examples like abixiban, indoxiban, and rivaroxaban. So you can notice in the name that we have XA, which is like the factor 10. So you can remember it in this way. Mechanism of action, from the name, it will directly inhibit factor 10, even if it's soluble, free in the blood, or if it's with a clot. For the clinical use, also it can use in prophylaxis and of the treatment in deep venous thrombosis, also to prevent stroke in atrial fibrillation. For the adverse effect, as we said, it's an anticoagulant, so it can lead to bleeding. And we need to reverse this bleeding or to treat it if it's heaviness, so we can use an humanized factor 10, which is andexanate alpha. Okay. Also, it's given orally. It doesn't require lab monitoring like the direct thrombin inhibitor. It can go elimination even by cytochrome B4015 dependent or without it. So it has some drug-to-drug interaction. Okay, so what are the advantages and disadvantages of direct oral inhibitor? The advantages, it's rapid onset of action. It has only to inhibit a specific coagulation factor. Also, we can use it in a fixed dosing. There is no need for monitoring, not like warfarin or heparin, no food interaction. And for the drug interaction, it's very few. Also, it can cause bleeding, as we said, but the bleeding here is less major bleeding than what happened in warfarin or heparin. Also, there is we can use it an alternative of heparin in venous thromboembolism. However, it has some disadvantages. So it has a short acting or short half-life. And this short acting will lead that we need compliance. So the compliance here is important, that the patient take the drug regularly. Also, it can be affected in renal function, in liver function, and it has bleeding risk. But as we said, the bleeding here is less than heparin or warfarin. Also, it's not recommended for antiphospholipid syndrome or mechanical heart valves. Okay, so now we will discuss another two coagulation disorders, which are von Willebrand disease and DIC. So in order to understand von Willebrand disease, we should understand what's the von Willebrand factor. So firstly, from where this von Willebrand factor is coming and the source of the von Willebrand factor and the synthesis, it's not in the liver like the other factor. Actually, it has two sources. The first one is the endothelial cell of the blood vessels contain what's called Weber-Balade bodies. And these Weber-Balade bodies will contain von Willebrand factor and release it. Also in megakaryocyte, these megakaryocyte in the bone marrow, megakaryocyte will formate the platelet. And in the platelet, we have alpha granules. And these alpha granules also contain von Willebrand factor. So von Willebrand factor, it's not synthesized in the liver, it's synthesized in two places, endothelial cell by Weber-Balade bodies and platelet in the alpha granules. Okay, according to the function of the von Willebrand factor, it's very important in hemostasis because it affects in both primary hemostasis and secondary hemostasis. So as my colleague discussed, we have primary hemostasis, which is platelet adhesion and then platelet aggregation, platelet activation, and then platelet aggregation. So the von Willebrand factor has a role here in the platelet adhesion. It will help in the adhesion of the platelet with the endothelium by the help of glycoprotein 1b. Also, it works in secondary hemostasis. So in the secondary hemostasis, it bound with factor 8. So it will form like a complex, factor 8 with a von Willebrand complex. So von Willebrand factor, it's like a carrier for factor 8. It will protect this factor, prevent the degradation of the factor, and prolong the half-life of it. So the function of it, very important in the primary hemostasis and in the secondary hemostasis. In the primary hemostasis, it helps in the platelet adhesion by glycoprotein 1b. In the secondary, it's a carrier for factor 8. So you can see here in this picture, we have primary and secondary hemostasis. In the primary hemostasis, it helps in the adhesion. So you can see that von Willebrand factor helps the platelet to adhere with the endothelium by glycoprotein 1b. In the secondary hemostasis, it's in the intrinsic pathway with a factor 8. So it will carry the factor 8, protect it and prevent it from degradation and increase the half-life of it. Okay, so any abnormality in this von Willebrand factor will lead to the disease, which is von Willebrand disease. So von Willebrand disease, it's the etiology, it's the most common inherited bleeding disorder. So it's one of the inherited bleeding disorder, 1% of the population. And it's the most common, so you can remember that it's an autosomal dominant. Dominant is most common because it will be dominant. So if one of the parents have the disease, like this affected parent, 50% of the children will have the disease. And it's either male or female, so it's not to a specific gender. So it's the most common inherited disease, and it's an autosomal dominant. Okay, for the pathophysiology, we said that it's abnormality in the von Willebrand factor. Either reduce in the level of it, so we have decrease in the von Willebrand factor, or abnormal function of it. So as we said, von Willebrand factor effect in primary hemostasis and secondary. So it will affect in the primary hemostasis in the platelet adhesion. So the platelet adhesion will be decreased. So the function of the platelet will be decreased. Also, it can affect in the secondary hemostasis. In the secondary hemostasis, it will bind to factor 8. So the factor 8 activity will be decreased. Okay, so for the clinical presentation, as we said, it's an inheritance. So it's usually come as a children, and with a family history, it's an inheritance. And the symptoms, usually it's milder and less than hemophilia. And as we said, it's effect in the primary hemostasis and in the secondary hemostasis. So we will have symptoms from primary hemostasis and the symptoms from a secondary hemostasis. From primary hemostasis, you can remember it as a primary is always superficial bleeding. So we will have mucocutaneous bleeding. We can divide it into cutaneous, which is a skin bleeding. So in the skin bleeding, we can have petechiae, purpura, or ecchymosis. Also, we will have mucobleeding, bleeding, which is mucosal bleeding, like epistaxis, which is a bleeding from the nose, or bleeding from the gum, or menorrhage. Also, we will have a secondary hemostasis. So the secondary hemostasis is always a deep bleeding, not a superficial like the primary. And this deep bleeding will be in the muscles and the joint, but it's rare in the von Willebrand disease. Usually, we don't have bleeding from muscles or joint or deep bleeding. Okay, the bleeding is usually after dental or surgical procedure, and the symptoms worsen with acetyl salicylic acid, which is the aspirin. So the von Willebrand disease, it's the most common inherited disease. It's an autosomal dominant, and we have an abnormality in the von Willebrand factor, decreased number or a decrease in the function. So the clinical presentation, it will be related to primary hemostasis, which is superficial bleeding, like mucocutaneous, or secondary hemostasis, which is deep bleeding, like from the joint or muscles. And we shouldn't give it with aspirin because it will worsen the symptoms. So here we have the skin bleeding. We have petechiae, purpura, and ecchymosis. All of them are skin bleeding, but the different in the size. So petechiae is the smallest one, and ecchymosis is the largest one, as you can see from the picture. Okay, now for the laboratory findings. So if you understand the pathophysiology of the disease, this laboratory finding will be easy for you. So first, we talk about here the pathophysiology, that the von Willebrand factor help in the primary and in the secondary hemostasis. So the laboratory finding will be related to the primary, also to the secondary hemostasis. In the primary hemostasis, it helps in the adhesion of platelet. So it will affect the function of the platelet, not the number. It doesn't work with the number of the platelet. It's only with a function of it, which is the adhesion. So the platelet count will be normal because it will not affect on it. However, the bleeding time, which is related to the platelet function, will be prolonged because we interpret this this function by inhibit the adhesion of the von Willebrand factor with the platelet. Also, it will affect in the secondary hemostasis. So in the secondary hemostasis, we have intrinsic pathway and extrinsic pathway. In the intrinsic pathway, we have the factor 8, which is responsible for von Willebrand factor. So it only affects in the intrinsic pathway. There is no relation with the extrinsic pathway. So the prothrombin time will be normal because the extrinsic pathway is normal. However, the partial thromboplastin time, or PTT, will be prolonged because the intrinsic pathway, which is factor 8, will be affected. Also, we will look for factor 8. So because von Willebrand factor, it's a protector for factor 8 and prevent its degradation. So it could be normal, but it may be moderately decreased. Also, the von Willebrand factor, the disease is about it. So we could have decrease in the number or decrease in the function or both of them. Also, we have a specific test for von Willebrand disease, which called risteucin-induced platelet aggregation. So we are going to add a risteucin to the blood and see if we will have platelet aggregation. So if we have a platelet aggregation, it's normal. But because we don't have the von Willebrand factor and we don't have the adhesion, so this will be impaired. So in the laboratory finding, the platelet count is normal. It will not affect on it. The bleeding time is increased because it will affect in the function of the platelet. The prothrombin time is normal because it will not affect in the extrinsic pathway. However, the partial thromboplastin time will be prolonged because it will affect in the intrinsic pathway. This is very important. Now, the classification, we have 3 types of von Willebrand disease. We have type 1, type 2, and type 3. Type 1 is the most common one, and this is what we was discussed here. It's type 1. Also, it's an autosomal dominant, so it's the most common one. It's a quantitative. Quantitative means that the number of the von Willebrand factor is decreased, not the function. So here we have the number. And it's not completely decreased, it's partial deficiency. For the type 2, it's functional abnormality. So it's a qualitative, not a quantitative. And it's an autosomal dominant also, and we have types of it. So we have 2A, 2B, 2M, and 2N. 2A, the main problem that the high molecular weight von Willebrand factor multimers is absent. We don't have high molecular weight or von Willebrand factor multimers. In 2B, the main problem that the affinity between glycoprotein 1B and the von Willebrand factor is increased. So we will have more complex of the platelet with a von Willebrand factor, and this we will be degraded. So the number of the platelet will be decreased. And this is the only type that we have thrombocytopenia, because usually the platelet count is normal, but here the platelet will be decreased. In the 2M, it's the opposite. The binding capacity between the platelet, which is glycoprotein 1B, and the von Willebrand factor will be decreased. In the 2N, the problem here in the binding capacity with factor 8. So the factor 8 binding capacity will be decreased. And we have type 3. So the type 3, it's the least common, it's rare, and it's an autosomal recessive. So you can remember that recessive, it's the least common. It's quantitative and complete deficiency. So it's a severe form of von Willebrand disease. And in type 3, we can see the deep tissue bleeding. Okay. So we have this question here. Anyone would like to read it? Anyone would like to read the question?
Yes, me.
Yes, please.
Okay. 25 years old man comes to the physicians for the evaluation of 6 months or history of the recent subcutaneous nosebleed. He said that he is able to stop the bleeding within 10 minutes by lights pinching his nose at the nostril. He has no history of serious illnesses except the prolonged bleeding, falling wisdom teeth exertions for 2 years old. 2 years ago. He doesn't smoke or drink alcohol. He takes no medications. Fetal signs are within normal limits. Examination of the nose shows no abnormalities. There are several prices on the lower extremities. The reminder of the examination shows no abnormalities. Laboratory studies show. Okay, and then here we have analysis.
Okay, so what do you think the answer will be? Okay, so let's solve it together. Here we have, in this case, it's recurrent spontaneous nose bleeding. So we have continuous bleeding, as we said here. We have mucocontinuous, like epistaxis, which is a nose bleeding. Also, he states that he is able to stop bleeding. Yes, he has prolonged bleeding, so the bleeding time is increased, and following with some teeth extraction. So as we said, also it increased after a surgical or dental procedure. And there is no other abnormality. Here, the hemoglobin is normal, so there is no anemia. The leukocyte is normal. There is no leukocytemia. The platelet is normal. The platelet count is normal. So here we said the platelet count will be normal because it doesn't affect in the number of the platelet. The bleeding time here is increased because it should be 9, but here it should be from 2 to 7, but here it's 9, so it's increased. The prothrombin time, it's normal. It's less than 15, so normal. The partial thromboplastin time, it's increased. So we have increase in the partial thromboplastin time, and also we have increase in the bleeding time. So here, because of the primary hemostasis, and here because of the secondary hemostasis. And we have here mucocontinuous or superficial bleeding because of the primary hemostasis. So the answer will be von Willebrand disease. Now for the second disease, we have DIC, or disseminated intravascular coagulopathy. So disseminated means it's all over the body. The bleeding will be all over the body. Intravascular means that the problem is inside the vessels. Coagulopathy means that it's a problem with a coagulation. So in DIC, we have a unique feature that we have a bleeding and thrombosis at the same time. So the etiology of it, it's an acquired coagulopathy, not like the von Willebrand disease. It's not inherited. And we can remember the causes by this mnemonic: stop making new thrombi. So it could be snake bite, it could be sepsis, which is infection, especially with a gram-negative. It could be trauma, obstetric complication, pancreatitis, malignancy, especially acute myeloid leukemia. It could be nephrotic syndrome or transfusion reaction after transfusion of the blood. Also, it could be acute respiratory distress syndrome. And you can usually find on the scenarios that the patient start with a sepsis. So he has an infection. And after the infection, he will start to have acute respiratory distress syndrome. And then after this, we will have the DIC symptoms. So the pathophysiology of DIC, any one of these causes can lead to entry of procoagulant material into the circulation. So the material that can lead to coagulation can enter to the blood, or they could lead to the damage in the endothelium. And this damage in the endothelium will lead to collagen exposure, and the collagen exposure can start the thrombosis. So because of this entering of procoagulant or endothelial damage, we will start to have coagulation inside the blood. So here we have a vessels, because that's why it's called intravascular. And inside the vessels, we either have endothelial damage or entering of procoagulant. And these two will lead to accumulation of the coagulation factor and platelet, and lead to starting of the coagulation cascade. And this will lead to microthrombi. This microthrombi or thrombosis will lead to decreased blood flow to organs. So it can lead to end organ damage, or also all the clotting factor, all the platelet and everything will come to this microthrombi in specific place in the body. So the amount of the platelet and the clotting factor in the body will be, or in the blood will be decreased, and this can lead to bleeding. So in the pathophysiology, we have both thrombosis, because we have damage or procoagulant material that lead to thrombosis formation, or we could have decrease in the clotting factor and the platelet, because all of them will come here. So we will start to have bleeding. So in the clinical presentation, as we said in the pathophysiology, it could be either bleeding or microthrombi, but the bleeding is much more than the microthrombi. And the bleeding could be bleeding from vein puncture side or from any other side in the body. It could be GIT bleeding, oropharynx, lung, vaginal bleeding. Also, we could have a microthrombi, which is less. So it can lead to skin lesion or decrease blood flow to an organ like renal failure, gangrene, or cerebral ischemia. And because here we have the thrombi that is made in specific blood vessels, it will decrease the diameter of the blood vessels. So instead of this, we only have this, it will decrease the diameter. So because it decreases the diameter, whenever the red blood cells try to pass from here, it will be degraded because it's a very small area. So because of this degraded, we will have anemia, which is microangiopathic hemolytic anemia. And also we will see in the blood film examination, we will see this degraded red blood cells, which we called it schistocyte. So you can see here, we have some schistocyte. So in the DIC, we have microthrombi that is formed in a specific place because of any of these causes. And this macrothrombi will lead to formation of the thrombus and also for bleeding, because it will consume all the clotting factor and the platelet. And also it will lead to microangiopathic hemolytic anemia because the red blood cells will be degraded here, and we can see schistocyte. So here it's a case of DIC. You can see the coagulation like here, it's a gangrene, and here we have a bleeding. For the laboratory finding, as we said in the pathophysiology, all the coagulation factor and the platelet will come to a specific place. So if we measure it in the blood, the platelet count will be decreased because it goes to this microthrombi. Also, the bleeding time will be prolonged because we decrease the platelet, so the function of it will not work. Also, the prothrombin time, which is responsible for external pathway, will be increased. Why it's increased? Because all the coagulation go there, either the extrinsic pathway or intrinsic pathway. Partial thromboplastin time, also it will increase because the intrinsic pathway is also effective. Also, we have a specific test here, which is the D-dimer. So in the D-dimer, also it will increase in the DIC. The fibrinogen will decrease because it will be in a specific place in the blood. And the factor 8, it will be decreased. All the factor will be decreased because they will go to a specific place. And this is unlike the liver disease, because the liver disease has the same as this disease, but the difference that the factor 8 is not decreased in the liver disease. Okay. Test 2 types, acute and chronic. So in the acute, the patient will usually come with bleeding. So he could have bleeding from vein puncture site into organ, bleeding from primary, which is ecchymosis or battegi, so bleeding in the skin. Also in the chronic, we will have bruising or mucosal bleeding. Also, we could have microthrombi that can lead to renal dysfunction, respiratory dysfunction, hepatic dysfunction, shock, or it can lead to neurological symptoms which are transient because of decreased blood flow to the brain. Okay, so we have this case. Who would like to read it? Anyone would like to read the case? Okay, so I will. Okay, I would read the case. A 66-year-old man is brought to the emergency department because of 3-day history of fever, chills, and altered mental states. According to his daughter, he has had a productive cough during this period. He has type 2 diabetes mellitus, hypertension, hypercholesteremia, peripheral nephropathic pain, and history of deep venous thrombosis. Current medication include insulin, lisinopril, atorvastatin, warfarin, carbamazepine. He is oriented only to self. His temperature is 39.3. Pulse is 110, and respiration are 26 per minute. And blood pressure is 86/50. Physical examinations show ecchymosis on both lower extremities. Crackles are heard at the right lung basis. And here we have the laboratory test. So what is the most likely underlying causes of ecchymosis? Anyone know the answer?
Yeah, disseminated intravascular coagulopathy.
Yes. So we can see that from the scenario, he has fever, chills, and productive cough. So he has a sepsis. He has an infection. As we said here, we could have it from a sepsis. So he has a sepsis. Also, here he has ecchymosis, which means that there is a bleeding from the skin, and crackle are heard at the right lung base. So there is a problem in the lung. It could be an acute respiratory distress syndrome. So as we said, we could start with a sepsis, and then this sepsis lead to acute respiratory distress syndrome, which lead to DIC. So here the hemoglobin is decreased. So he has an anemia. As we said, we could have microangiopathic hemolytic anemia. The leukocyte is normal. The platelet count is decreased because the platelet will go to a specific place. The prothrombin time is increased or prolonged because the extrinsic pathway will be affected. The partial thromboplastin also prolonged. And so all of these manifestations, everything is abnormal. This will lead that we have DIC, disseminated intravascular disease. And that's it for today. Thank you.